So you can see the authors here. There's a bunch of them, right? Just the second
Yes.
here. And Gabby was my doctoral student, and she developed, proceeded to use this approach to see something about customizable treatment of patients. So do you want to do if a patient is different, or you want to do a patient that looks like it's similar to other patients, and we're going to say we'll do the same treatment as the group. So let me explain what that means. Um, okay, how do you go forward? I can't go forward. What? Okay, no, I can't move it. Oh,
Why?
I don't know. Oh, there you, oh, I have no idea. Um,
No, you
was I okay
can
before?
move it. You can
Yeah,
move
we
it,
can see.
please.
If I make it big, I just made it bigger. See?
Click. Yes.
Okay, so now I just moved. The purpose of the paper is to show you that should you want to find out what the preferences of patients are for a particular procedure, for example, a diagnostics for colon cancer. So the question is, people have preferences for the procedures that they can have. So what we're trying to do is to find out, should we treat each patient individually, or should we treat the patient as belonging to a group for which we already have a treatment pre-described? Okay. So if I do this, let's say go forward. There you go. So here are some references. I'm not going to list them. These people that talk about personalized, what do you call patient, what do you call it?
Patient care.
Well, it's a between the patient and the doctor. They have to make a decision. Is it an individualized treatment, or is it a group treatment? So not as a group, you belong to a certain group, given some demographics. You see the example. So what happens is that to be able to do this, you need to know the preferences of the patient. So Jim Dolan, you probably remember Jim Dolan
Okay.
many years
Yes.
ago, right? He had a set of patients that he had asked preferences about what kind of procedure do they prefer to do to diagnose or to prevent cancer of the colon. Okay, and so based on those patients that he had there, Gabi decided to do a study of should we, because it costs you money to do individualized preferences, you have to keep asking questions to them, right? And that takes time and it's time consuming. Or you see a patient and say, oh, patient that looks like another patient over there. And so therefore maybe we should do similar treatment in terms of the procedure to use. So the whole idea was to study the stability of the preferences. Okay. That was a different paper in 2012. I think it was published in the European Journal where we study stability in a different way than the stability for the ANP than it usually is done. So I have to, what happened to my thing? Okay, I'll click again. Oh, there you go. So here, give me a very simple example of the stability of preferences so you understand it. This is a case where you have three criteria and three alternatives. And the reason for three criteria is because you only need to change the priorities of two of the criteria because they had to add up to one, obviously. So when you change it, so I can make a three-dimensional picture. So the picture looks like this. So as you change, you perturb criteria one or criteria two, one alternative becomes dominant. So there's a space, there's an area of the perturbation space that belongs to A1, to the one alternative. The alternate these regions don't necessarily have to connect all the time or touch each other all the time. But in three dimensions, this can happen. Uh, the 0, 0, 0, the point in the middle means this is the original solution. But when you perturb the criteria weights, you move away from, and A1 was the most preferred, you move away from the A1 to maybe A3 is the preferred alternative. So this is a study in the perturbation space. Um, so if you were to do this as you can see, by the way, that you can show that the regions don't have holes. You can go from one region to any other region, passing through other regions. So this called strongly connected. And they're also, as I said, it doesn't have to be, they don't all connect to each other. In three alternatives, it's easy. You can see that will happen. So, but when you have many alternatives, like the case is in perturbation spaces dimension M, then what happens is that some areas will touch each other. So you have an alternative that's dominant, and then when you perturb the criteria to move to another alternative, so there's another area which is dominant. So that's what the stability means, is how much do I have to perturb the criteria weights to move to another alternative, to be more preferred. And to answer that question is you have to find out, well, how far is the center of the region they are thinking about from the different boundaries of the alternatives that are available to you. So it turns out to be that as you can see in the previous slide, you could go from A1 to A2, or for A1 to A3, or from A3 to A2, and so on. So the question is, you study the preferences of the patient based on the perturbation space, and so you can see that, for example, you have, in this case, we had 6 criteria. These are the criteria for a given patient. And these are the priorities that this patient assigned according to criterion 1. This is how the patient preferred these alternatives. And I'm going to show you the alternatives. These are the alternatives. The alternatives are colonoscopy, double contrast barium, enema, and so on. So these are the solution for that patient. Okay? So, but the question is, if I change the criteria weights, I can't put it in a graph because it's 6 dimensions. So I have to think about, we prove mathematically exactly that the region doesn't have any hole, it's convex, and the regions touch each other, but not all of them. Some of them touch each other. You may not go, for example, from the most preferred alternative, which in this case was A10 for this patient. You may not be able to go to annual fecal occult because there's no way of perturbing the criteria weights to get there. So in this particular patient, you can see that if you are originally the alternative that is preferred is A10, but when you perturb the criteria weights in this form, you get to A1. This is the first boundary, okay? That's the region in which A1 is most preferred. Then it also can reach A3, and also can reach A5 and A8. This is an optimization model where you change the criteria weights to say, I'd like to go from A10 to A2. But if there is no feasible solution, I mean, I cannot perturb the criteria weights to get to A2. That was the whole idea. So you know which one is closest to you. For example, it says this is the minimum switch distance traveled in line, and this is the farthest from there, A5. So you can move from A10 to A1 or from A10 to A5. So you could think about this in a sense as, how do I have to prioritize the criteria, change the way the patient thinks about the criteria so they move to a different alternative. It could be a dialogue, so to speak. Okay, so now doing individual assessments of these individual preferences is time-consuming. Dolan only had 405 patients. I think we could clear up about 395 he let us use. And of course, he said these are the preferences I got, but it took him a long time to get them. In fact, he had a commissioned study to be able to do that. So the whole idea is that either you do an individual analysis of all the patients you have in your clinic, or you take a past history of the clinics for which you do analysis of their preferences, and then from that set of patients that you have there, I can now try to do some sort of groupings in terms of the preferences of the alternative they prefer. Remember, this was done for cancer prevention, colon cancer prevention. And we use the guidelines from the medical association. So the whole idea is either the patient falls in a category, in a similar category, and I can treat it that way, in which case I don't have to ask for preferences again. I'll say, okay, if you look similar to that group over there because of your demographics, then I'm going to suggest that you have this particular procedure done instead of colonoscopy, for example. Otherwise, you'll have to do the individual. So each of the groups in which the patients fall is called a stability group, and then we have to cluster the patients in different groups. These are the kind of patients we had. We had 395 patients from 3 locations, male and female, and age in this area. And then what we did, because we didn't have, remember that we would like to be able to classify a patient. We ask them questions when they enter the clinic. We don't do we don't do an individual analysis yet. What we're going to do is we're going to see, based on the demographics, assign it to a group. Let's see how good we are with that. Of course, you say, well, everybody should, but that's more costly, cost you more money. So we incorporated some data, and this is all in the paper. So the paper is really long paper, exploring all the details. So the whole idea is to do clustering. So we use two types of clustering, two-step clustering and K-means clustering. And these are the initial features that you have here. A most preferred alternative because these are for the individual patients, we have these. Number of switches, minimum switch distance, minimum switch alternative, they call it. Okay, so the two-step clustering use the log likelihood metric and archaic information criterion. And then we use it called the silhouette measure. Is how well are we clustering? So how well do the patients fall within the cluster that you have? It's actually, if you type silhouette measure average in Google, you'll get the whole description in Wikipedia what to do with that. So we use the two-step clustering give you better similarity in the groups. So we kept it like that. So for example, here you have what happens when you use the two-step clustering. You have A10. If you chose A10, you fall in a category. If you chose A3 or A2, you 100% of them, A10 also, they had a minimum switch alternative A3. Okay, so you saying, oh, I see. You prefer A10, but if I can convince you that A3 is a good alternative for you, I'll try to convince you to do that. Only 10% fell in stability 2 and group 3. So the whole idea is to say, okay, what I need to do now is to using some objective features, right? Like gender, age, location, income, and education, which we assign them randomly to do a test that we were trying to do, is we had to find out, predict, where does this patient, so we divided the data in two parts, right? The training method and the prediction method, the testing method. So the whole idea was that this is how C5 is one of is a classification model, have 50 or say 83% accuracy here. The coincidence matrix, that falls in the right category. And you can see that CART was a little better. But so the whole idea is you have a patient enters the clinic. We have already built our stability groups and have to make a decision about should I assign the patient to do an individual analysis, or should I individual analysis for the preferences, or should I assign it to a group? So this is what happens. Now you have to make a decision, how many groups do I want to use? So if I don't use any groups, you can see that I'm 100% okay. I know exactly what's happening. But if I have one group, CART, C5 is a little better than CART. But as you increase the number of groups, obviously, you're going to save money, right? Because you have to look at less patients individually. So you can see there is a cross at one point in time with 3 groups. Percentage classified perfectly is in CART, and both of them. So in the middle, you can see 2 groups. You save more money. CART is better than C5, predicting in which group would the patient fall. So that was the whole idea of doing that. Group customization versus individual assignment. So how do you do this? Well, you take a group of patients at the clinic and you have to build your own data, right? And once you have your data, you can actually try to build a model, find out how many groups stability groups I need to build to save money and time. That's what the time is. So that's what group customization is about. So as an example of it. As I said, we only had 395 patients, not very large. So the whole idea is to find out, is it worth to do group customization or versus individual? Individual means I have to ask you what your preferences are, and that's going to take time. So if I look at you and say, oh, based on age and gender and maybe location, income, and education level, if I ask those questions, in which group do I classify you correctly? Or should I do an individual if you don't fall in any group? So that was the idea of the paper. I mean, I simplified it a lot, obviously, because a lot of the paper is dedicated to the clustering and to the classification approach used. So, how did I do? This
Okay,
question.
Luis. Anybody have questions?
And I have some of the references mentioned here, but if anybody wants to have the actual paper, and all you have to do is ask me, and it's being revised now for, it's almost accepted in the multi-criteria decision analysis journal.
Luis?
Yes.
Luis, this is something like, sorry, the question, just to try to understand. This is something like you try to predict the selection of the patient.
So you're trying to predict what would the patient want to have done, what kind of procedure, right?
And okay, yes.
So either
the procedures, but I mean, what do you want? What you want to do is to see if what is the selection of the patient.
Right. But if you know the preferences of course you know what the preferences are, right? But before you do the preferences, the ask for all the preferences and all the pairwise comparisons, you say, okay, based on some objective features that I know the patient, like you are male, 50 years old, from Black, with a certain income, and we just invented these objective measures just for fun. And I say, oh, maybe this patient should follow category stability group 1, and so that's the advice. So you save time in terms of having to do all the pairwise comparisons. So obviously, if you don't want to do that, everybody has to be treated individually, in which case it's much more time consuming. So that was the idea of the process. Find out what the patient would like to have done.
Okay, so you're predicting what the selection of the patient. But
right.
Do you have any kind of way to prove that prediction is close to the final election?
Oh yes, that's what the predicted set was for.
Okay, and you have applied in
not in real life. This is only for that data set. We divided the data set in 2 pieces. One was the training set, building the stability groups, and the other one was saying, let's predict for these patients that I have with only the objective measures where they would fall in terms of their preferences for the procedure to be done.
Okay.
So it's a basic data mining approach.
Mario, you're muted, Mario.
You're muted. We can't hear you.
Luis, thank you. It's not easy to understand the model, but if you have the patient that they choose some alternatives, they know what imply the alternatives, and you need to educate this population.
Sure.
And then if you have alternatives, similar alternatives, okay, it's more easy, but the alternatives to predicted in medicine is very not equal all. If the colorectal endoscopy or the test for the finger for the prostate cancer or colorectal cancer are totally different in their results, and then
right.
It's not easy putting practice manner.
Correct. And so we asked Jim Dolan, who was the doctor who did the initial study, tell us which for each of the procedures, which criterion is more accurate. Tell me what is better for. And so he gave us that data, and that's how we build the ANP model. Okay, so it's not just that you have preferences for the different criteria from the patient. It actually came from a doctor. So I'm saying colonoscopy. What is colonoscopy good for? Best for the criteria that you have. Now, of course, it's possible that you don't have any information, right? So I'm with you.
Uh-huh.
So that's tough to predict what the patient should prefer. I suppose the doctor advising all the time. So So the idea is to have the doctor and the patient making a decision together. That.
Of course, that's.
So I'm with you. It's not an easy problem. I agree. But the doctor, sometimes there is statistics for that, right? That was I said, how do you know? So we asked Jim Dolan, tell us for colonoscopy, tell me what's colonoscopy best for in terms of the criteria. And that changed. And obviously you have a super matrix. And then when you solve the super matrix, all those criteria weights become one in the limit. And then you have a consensus, so to speak, about the criteria importance and the limiting priorities. But getting those priorities for the criteria with respect to each of the alternatives, that was the difficult part. And I don't know how good that is. I have no statistics to compare with anything. But that was the intention.
Okay.
Thank you for the question.
Thank
you. It's a way to walk.
Yeah.
Okay.
Well,
if there's no more questions, we go for the next presentation that casually is mine.
Thank
what
you.
A coincidence.
What a coincidence.
Oh, it's like you. Oh, that's right, you.